is there, we can start.
Okay, so the first speaker is Dr. Atira Devraj, and she'll be talking on prognosticating Strasser syndrome, a case series from North Kerala.
Was it 6 minutes? First speaker.
Yeah.
Is it 6 or
7 minutes.
6 minutes? 6 minutes. It is 6 minutes. 6 plus 1.
Yeah.
6 minutes.
Yeah, correct.
Here it is 6 minutes. I don't know. Actually, most probably 7. I think can you just take up?
I will call back.
No, they were
Evaluating paper it is written 7.
just
Just verify. Could be 7 because all other
PT
only 6.
So can I start?
1 minute.
Okay.
Correct. As you say, it is only 7. Is it given 7? This is KGR. So you all prepared for 7 minutes?
Okay,
We'll
fine,
go ahead
fine.
with 7.
Go ahead. Okay, fine.
7 pa. Happy? Yeah, go ahead.
Okay, fine.
So
But 7, before 7, after 7, marks will reduce. Okay? Yeah, go ahead.
So good afternoon, everyone. Today, I'd like to thank KSOS for this opportunity, and I'd like to take you through a case series of Strasser syndrome and discuss various prognostic factors. So Strasser syndrome was first described by Bradley as Strasser as a syndrome of unilateral myelinated retinal nerve fibers, axial myopia, and amblyopia. We all know the myelination stops at lamina cribrosa because it acts as a barrier preventing migration of oligodendrocytes into the retina. And the type of myelination can be of 3 types. In type 1, only the disc and one arcade is involved. In type 2, both the arcade and the disc is involved. And type 3, the disc is paired. There is a debate whether the blurred image due to the myelination and axial myopia is causing the axial myopia and amblyopia, or the axial elongation of the globe causes late closure of the lamina cribrosa and myelination. The visual impairment in these patients can be due to the functional amblyopia due to anisometropia, which is treatable, and the organic etiology due to impeded light transmission by the myelinated retinal nerve fibers, which is not treatable. So the case 1 is a 9-year-old female with a defective vision in the left eye with an axial myopia of -6 diopter with no strabismus. And as you can see in this picture, there is 9 clock hours of type 3 myelination, but it is not involved in the fovea as evident from the OCT. So this patient was treated with full-time optical correction with a part-time occlusion of the right eye, and at 10 months follow-up, a visual acuity was 6/12 parts. Here the good prognostic factors in this patient is no strabismus, no foveal involvement and type 3 myelination, but high anisometropia and late diagnosis has led to a final visual acuity of 6/12 parts.
Take a deep breath first, relax, and then talk. No problem, we'll give you 5 seconds for that.
Case 2 is a 7-year-old female with a defective vision in the right eye with a -10 diopter of axial myopia with an exotropia of 25 PD and hypertropia. And here he has a type 2 myelination which is dense and it is encroaching into the fovea region. And 6 clock hours of involvement is there. In the OCT, there is a chysis cavity and ERM. So this high anisometropia, strabismus, foveal involvement and type 2 myelination has led to a poor prognosis in this patient. Even after full correction and part-time occlusion, the patient vision didn't improve at last follow-up at 10 months. Case 3 was a 24-year-old male who with a defective vision in the left eye with axial myopia and strabismus, and there is type 2 myelination which is dense and involving 7.5 clock hours, and the OCT there is impedance of the retinal nerve fibers by retinal layers by the myelinator nerve fibers. So, foveal involvement with type 2 dense myelination, high anisometropia, delayed diagnosis and strabismus has led to a poor prognosis in this patient. Case 4 is a 9-year-old female with defective vision in the left eye with anisometropia of 1.5 diopter axial myopia with 2 clock hours of only type 1 myelination, and the fovea was spared. Here, the patient had no strabismus, no foveal involvement, there's type 1 myelination and relatively early diagnosis with low anisometropia. With full optical correction and part-time occlusion, the vision has become 6 parts at 6 months follow-up. Case 5, the last patient had an anisometropia of 4.5 diopter with no strabismus, and there was 4 clock hours of type 2 myelination, and there is no involvement of the fovea. This patient had no macular involvement, no strabismus, and relatively early diagnosis, and at 6 months follow-up, her vision improved to 6 parts. Here we had 5 patients with age ranging from 6 to 24 years. Early age diagnosis presentation allows for early intervention and thus a better visual outcome. There was no strong evidence in the literature for any particular gender predilection. The higher amount of anisometropia and the initial visual acuity is associated with poor prognosis. Terabashi et al. Has found that whenever the final visual acuity, whenever the refractive error is less than 5 diopter, the final visual acuity was better. In this series, we had 2 patients with strabismus, exotropia and hypertropia. Multiple studies have shown different patterns of strabismus, but this can be because of the racial factors, as exotropia is more common in Asians, while esotropia is common in non-Hispanic whites. 3 of our patients had type 2 myelination, whereas case 1 had type 3 and 4 had type 1 myelination. The 2 is associated with worse prognosis, and the more extensive myelination is associated with higher degree of myopia and poor visual prognosis. Key et al. Has found that whenever there is more than 9 clock hours of involvement, it is associated with the worst prognosis. And the foveal involvement is associated with the worst prognosis. In case 2 had a cystic changes with ERM, and most of the times it is an overshadowing of the outer retinal layers due to the extensive myelinator nerve fiber. And when we compared the mean axial length of the affected eye to the fellow eye in this patient, there was a significant difference, but the mean corneal curvature was comparable, making it obvious that there is an axial myopia in these patients. So, the poor prognostic factors included high degree of anisometropia, extensive myelination, and type 2 myelination, strabismus, macular involvement, and poor initial visual acuity. Late ages diagnosis, high anisometropia, and timely diagnosis and full optical correction with aggressive amblyopia therapy can lead to unexpectedly good results in this patient. Usually, Strasser syndrome is considered to have a poor prognosis, but every case should be approached optimistically and every attempt should be made to provide full optical correction and extensive amblyopia treatment. Thank you.
Relax, ma'am.
Yes.
So, even if MNF was not there, with foveal hypoplasia, high refractive error and strabismus, the same would be the outcome unless MNF comes in the macular area or is going to cause a significant, isn't it?
Yes, sir. But whenever there is a macular involvement, the
Absolutely.
refractive,
Correct.
yes, sir.
So you are just correlating the association with MNF
Yes.
and what is the probable cause for defect. Correct, I agree.
And which all can be the good prognostic factors. So whenever we see a patient with that, most of the times they will ask, okay, what will happen to my child?
Correct.
So we can tell them these are the good prognostic factors in this patient. So with the extensive amblyopia treatment, there is a chances that her vision will improve because the anisometropia when it is getting corrected.
As you
But
said, the age of
age of
correct.
onset also.
Now, what was the longest fallout?
One was that, those children with the 6 pass, they are on annual follow-up. So I have seen them for the last 1 year follow-up
So
only, sir.
small. You
Yes.
think noting this with the 6/6 vision all corrected in your case record will help you anywhere in the future?
I didn't get your question, sir.
Supposing you mark
Yes.
this, you
Yes.
draw a diagram or a photograph,
Yes.
mark it in your EMR or case record, and they keep on. They are from your local place. You think this finding? Supposing you're from which college? Which place?
I am working as a consultant in Kannur Jyoti Sai Care now.
No PGs from there, no?
I did my PG from Japan.
Because yesterday we had an extensive presentation by a PG with MNF, but it is not the same cases. I know that. So that is good. I'm happy. Thing is, if you mark or your junior doctor
Yes.
doesn't mark, will it have a any kind of effect?
It's like, if the demyelination is marked,
Marked.
if it is not, if there is a regression of the myelination, it can be a sign of demyelination.
So that is very most important. No, when demyelination comes, this will become smaller. So that is also an indirect.
Indirect.
Good, ma.
Thank you, sir.
Yeah, this is fine. Okay, fine. Go ahead.
Yes, please.
So this is only the myelination is only affecting on the fovea. Otherwise, all other cases, all cases without a foveal involvement.
No, sir. The two of the cases had foveal involvement.
So the prognosis is mainly on the refractory error changes, no?
Yes, sir. The degree of anisometropia as well as the strabismus pattern.
And the age of detection.
Age of that.
Thank you.
Thank you, sir.
Dr. Nina R. Evaluation of functional and cosmetic outcome after surgical correction of monocular elevation defect.
Very good afternoon to one and all. And my aim was to analyze functional and cosmetic outcome after surgical correction of monocular elevation defect. As you can see here, monocular elevation defect is a challenging strabismus which is characterized by limitation of elevation in all cases, both in adduction and abduction, with normal adductions in other cases. It is often complicated by presence of abnormal head posture, ptosis, which can be true or pseudo, presence of Marcus-Gunn jaw-winking phenomenon, horizontal deviations, DVDs, and amblyopia. So this was classified into three types based on the presence of Bell's phenomenon, the behavior of the FDT, and the other elevation saccades. So type 1 is a restrictive type with tight inferior rectus and a positive FDT. Type 2 is a superior rectus paralysis kind of condition with a negative FDT. And type 3 is a typical supranuclear MED with a preserved Bell's phenomenon and a negative FDT. So the aim in this study, what we did was we did a retrospective analysis of all patients with monocular elevation defect who underwent surgical correction at our center from 2022 to 23, and we compared the various surgical techniques with a minimum follow-up of 6 months. So these were the parameters we assessed. Apart from the demographic factors, we looked into the amount of hypertropia, the severity of elevation limitation, and the presence of other characteristics like AHP, ptosis, Marcus-Gunn jaw-winking phenomenon, Bell's phenomenon, horizontal deviations, DVDs, refractive errors, BSV, amblyopia, and we did an FTT for all patients. So coming to the surgical planning, the amount of hypertropia, status of the forced duction test, presence of abnormal head posture, true ptosis, Marcus-Gunn jaw-winking phenomenon, horizontal deviations were key determinants in our surgical planning. So if we had a type 1 MED, we mostly advocated a weakening of the inferior rectus with or without superior rectus strengthening. If we had a type 2, we mainly advocated a transposition surgery to the superior rectus, and a type 3, a combination. So when we had a larger hypertropia, toe muscle surgery was planned. Ptosis, true ptosis, and Marcus-Gunn jaw-winking required additional ptosis surgery, and this was conveyed to the patient. And horizontal strabismus surgery patients were told that they would require additional surgery in the contralateral eye, and a surgical success was defined as a vertical deviation less than or equal to 4 prisms of hypertropia with reduction in abnormal head posture with or without restoration of the binocular single vision. So coming to results, we had total 9 patients, slightly more females, Most of them were in the younger age group. 13.55 was the mean age. All were congenital MEDs. Abnormal head position was seen in about 55.5% patients. Ptosis was the most common complaint. Marcus gun jaw winking was seen in about 44.4% patients. The mean pre-op hypertropia was 26.7 for distance and 16.4 for near. And DVD was seen in 2 and horizontal deviation in 1 patients. Refractive error in 44.4% patients and amblyopia in 66.67 patients. We had mostly type 2 MEDs. So if you look at the Bell's phenomenon, it was absent in 55% patients and FTT was negative in those. So if you look at the type of squint surgery, most of them underwent a transposition surgery. And if you look at the improvement in elevation, you can see it improved very well from -2.89 pre-op to -0.56 post-op. And the hypertropia for distance fell from 26.78 of a mean deviation to 3.3 post-op. And hypertropia for near also improved from 16.44 to 0.89 post-op, and all these were statistically significant with significant p-value. So in our study, about 88.8% of the ptosis improved, although 4 needed additional ptosis correction. 80% of the AHBs improved, 75% of the chin elevation limitation improved, and 71.4% with preoperative suppression for distance regained fusion after surgery, and 85.7% regained near stereopsis better or equal to 100 arc seconds. So this gives you the improvement in the stereopsis from 92.5 to 52.5 post-op with a significant p-value. So coming to a surgical success, you can see some of these. This child had a type 1 MED with a very small hypertropia and a positive FDT. We only did an inferior rectus recession and she was good. Type 1 MED with positive FDT and ptosis. This gentleman had to undergo an inferior rectus recession in the same eye with a superior rectus resection and finally a ptosis correction, and he's well corrected. This lady had Marcus gun ptosis and she required, along with vertical muscle surgery, she required a ptosis correction also. Negative FTT type 2, we did a NAPS procedure. You can see here the wonderful improvement in the hypertropia post-surgery with good alignment and good improvement in the ptosis. Type 2 MED, we can also do this procedure which is known as a modified Nishida, in which no tenotomy, no disinsertion of the muscles, and we just transpose 1/3 of the muscles in the superolateral and supromedial compartments of the sclera with a non-absorbable sutures, and you get good alignment. Type 2 MED with Marcus gun ptosis is more difficult to manage. This child had an augmented NAPS but will require more surgery for ptosis. So again, horizontal surgeries required R&R in the other eye, that is recess resect in the normal eye for the horizontal deviation and a vertical rectus surgery, or a NAPS procedure. This child had a NAPS in the concerned eye. So what did we find different in our study? In our series, we found that small hypertropias less than 15 prisms in type 1 MEDs did well with inferior rectus weakening alone. And we found that ipsilateral superior rectus strengthening procedure was more acceptable to correct the residual hypertropia. And now in type 2 MEDs with negative FDTs, NAPS procedure and modified Nishidas were equally effective in improving the hypertropia. And true ptosis and Marcus gun jaw winking phenomenon needed additional ptosis correction. Surgical intervention and occlusion therapy improved the binocularity and amblyopia in our surgery, and good cosmesis with good improvement in AHP was seen in all patients. So study is relevant because this is one of the few studies to analyze and compare the surgical options in MED, especially associated with these complications like ptosis and Marcus gun. In the end, I'd like to sum up and say that identifying the type of MED, appropriate surgical planning, and staged surgery will give you satisfactory cosmetic and functional surgical outcome in MEDs. Thank you very much.
Okay, your presentation is about your outcomes.
Yes.
So it is good, there is no doubt. I would have been a lot happier. There are studies which have, vertical muscle have been treated, and there are publications. If you had compared yours with that in the study, you put some references,
Yes,
but
yes.
I can't talk. It is hardly readable, but we
Yeah.
don't know the outcomes.
Yeah, so most of the previous surgeries...
No. In your presentation, you asked for 7 minutes, we gave 7. No, it should be there in any study, then only we will also understand whether you're doing something different that is outcome better or it's line with the other outcome.
So-
Definitely, if it is bad, you will not present. We understand that, but it should be somewhere in your presentation. Always comparison of that is my that's my opinion, sir.
One case you did a doses correction.
No, 4 patients needed
patients.
additional ptosis corrections because they had true Marcus gun jaw winking also. And
Sling procedure, which is
for patients with type 1 MED with true ptosis, we just did a levator excision, but those with Marcus gun often needed a sling also.
which is sling?
Yeah, sling frontalis.
Frontalis.
Yeah. Patients were not agreeable to both eyes. We had to do it in. Yeah, ideally, but moving possible. So if I can add, previous surgeries have done surgeries for the residual hypertrophy in the contralateral eye, but we have tried to do it in the same eye. That was the difference we noted in our study.
Doing practically and really presenting that. Good.
Yes, thank you.
Thank you. The next speaker is Dr. Shibin Salim, microbial keratitis and thyroid eye disease.
Thyroid eye disease is complex autoimmune inflammatory condition. Sight-threatening TAD could be either due to dysthyroid optic neuropathy or exposure keratopathy related complications. So the tear film itself is unstable in thyroid eye disease. This along with lack of thalamus and exposure keratopathy further predisposes for microbial keratitis. So this is a retrospective case series of 3 patients. Clinical features, microbiological profile and management outcomes were studied. The microbial keratitis was diagnosed based on clinical features alone or with a microbiological confirmation. So this was our first case, 50-year-old gentleman who presented with the right eye swelling, decrease in vision of 7 weeks duration. He was elsewhere diagnosed as a case of active thyroid eye disease and has already received 2.5 gram IVMP before presenting to us. He had multiple systemic comorbidities, and on examination his visual acuity was counting finger 2 meter in the right eye and 618 in the left eye. There was lid edema, lack of thalamus, extraocular movement restriction, severe chemosis, conjunctival congestion, carangular inflammation. This along with the spontaneous and gaze-evoked orbital pain, the clinical activity score was coming 6 out of 7. So this was his right eye cornea. There was severe exposure keratopathy with a focal anterior stromal infiltrate and hypopyon. So he had both eyes non-proliferative diabetic retinopathy, imaging by MRI scan of the orbit showing bilateral enlarged extraocular muscles, which is more on the right side with apical crowding. So the challenges here, on one side we have active thyroid eye disease and the other side possible infectious keratitis with the multiple systemic comorbidities. The first priority was managing the infectious keratitis. The corneal scraping was done, which did not reveal any organism. He was started on empirical treatment. For the ocular surface protection, we did an right upper blepharotomy with lower lid retractor release, lateral canthotomy, cantholysis and tarsorrhaphy. For controlling the orbital inflammation, he received 1 dose of injection dexamethasone followed by low dose oral steroids and later systemic immunosuppression once the corneal ulcer started healing. So why we have to do such an aggressive ocular surface protection? Because if you do tarsorrhaphy alone, this in turn increases the intraorbital pressure and compresses the optic nerve if the apex is already crowded. That was the case here. So we have to do the additional relaxing procedures. Also, the tarsorrhaphy alone will not be effective in covering the ocular surface in this kind of severe thyroid eye disease, and it can give away because of ongoing orbital inflammation. So this was a 2 weeks follow-up. At 1 month follow-up, this is the last follow-up 14 months. We can see that visual acuity in the right eye improved into 6/12. This was the second case, 66-year-old lady with bilateral severe thyroid eye disease, sight-threatening thyroid eye disease. And here we can see that the clinical activity score was 7 out of 7. So this is both eyes cornea. Here there was severe exposure keratopathy on both sides with a focal infiltrate on the right eye. Again, the fundus right eye had no view, left eye had disc hemorrhages and edema suggestive of compressive optic neuropathy. The imaging confirmed the same. So again, this case also was managed in a similar way. Here the initial scraping showed fungal hyphae in the KOH and the culture revealed Aspergillus species. So patient was started on topical and oral antifungals. The ocular surface managed as before, and since she had compressive optic neuropathy, we gave 1 more dose of IVMP, but following which the intravenous steroids were deferred because of the active infection and switched into low dose oral steroids and later as the systemic immunosuppressant once the corneal ulcer started healing. She also underwent optic canal and orbital decompression because of the compressive optic neuropathy. At 6 weeks, the ulcer was healed and the edema reduced, and she also underwent orbital radiation once the ulcer is completely healed. This is at 6 months follow-up. She had cataract, underwent cataract surgery, following which she started pursuing diplopia and hence underwent squint surgery also. Final follow-up at 3 years, right eye visual acuity improved to 6.9, left eye 6.6. The third case, 54-year-old lady who had an active TED in the left eye with a clinical activity score of 6 out of 7, and she had severe exposure keratopathy in the left eye and a stromal infiltrate. Here we can see that, and hypopyre. So for her, this is the CT imaging showing bilateral enlarged extraocular muscles with apical crowding. So in this case, again, the initial corneal scraping was negative. She was started on empirical treatment. The ocular surface was protected. So for the orbital inflammation, following 1 dose of injection dexamethasone, she was started on low dose steroids and immunosuppressants later. She was improving, but unfortunately at 3 weeks follow-up, she had an increase in the corneal infiltrate with thinning and hypopyre, and increase in the medial exposure again. So repeat scraping was done, which showed aspergillus, started on antifungals. The medial blepharotomy and tarsorrhaphy was repeated. Also underwent blepharotomy and lateral tarsorrhaphy in the right eye also because of exposure. So following which, once the ulcer healed, she underwent orbital decompression and radiation. At 7 months, visual acuity in the left eye improved to 624. So microbial keratitis in thyroid eye disease is very rare, less reported. Only one large series is there of 13 patients. So here we can see that while all 3 patients in our series presented the focal corneal infiltrate, in the previous series it was advanced keratitis with more than 75% of patients. And there the organisms were mainly bacterial, while we had Aspergillus species in 2 out of 3 patients. In their study, evisceration was done in 4 patients, penetrating keratoplasty in one. And we did an aggressive ocular surface protection. TED was managed tailored to each patient. To conclude, antimicrobial treatment, ocular surface protection, and controlling the disease activity all are equally important for a optimal outcome. Thank you.
So all the 3 had microorganisms in the second time, huh? First one and the
2 patients, sir.
first one we don't know.
No, sir.
So not sure whether it's microbial, but clinically it looked like all the 3 cases look like acute exophthalmos.
Yes, sir.
All are acute exophthalmos, and not surprised cornea is getting involved. Once they come late, it will be an involved cornea. Absolutely. So I would have been happier if you had put the thyroid levels, and you just mentioned low TSH in one case, but you should put the thyroid levels. That will also determine what you should do to control the thyroid. You have managed all that too with the compressive optic neuropathy. Getting 6.9, huh?
6 in one eye and 6.9 in the other eye.
That is, you have treated well, but the thyroid parameters are equally important in this. And then you have to control whether it's hypo. It could be hyper, could be hypo, or anything. No, so including
it was controlled.
You make a mention of that. Yes. That is equally important.
Okay. Thanks.
Thank you, ma.
The next speaker is Dr. Jiminy Isaac. Neuro-ophthalmological confounders for optic dyscoping when it is not glaucoma.
Shall I start? Okay. Good afternoon, everyone. We ophthalmologists are well celebrated because we are protecting vision. Suppose we are able to protect along with vision life as well. How marvelous it will be. This is all about my study. We will see at the end of study how it will be possible. My aim of the study is to introduce 2 confounders which mimic glaucomatous dyscoping, but missing it could be dangerous for vision and life as well. We selected 85 patients for the duration of 8 months from a tertiary care center in South Kerala, and patients above 18 years with optic disc cupping, which if proven to be glaucomatous, were selected for the study. So, if all the selected patients were undergone thorough evaluation from our glaucoma department with the help of OCT, CCT, visual fields and slit lamp biomicroscopy to confirm that these cases are non-glaucomatous, and we proceeded with the study, and we included patients above 18 years of age and a subject cooperation for media clarity and good fundus and OCT pictures, and OCT signal strength more than 3 were also included. We excluded all the suspicious cases of glaucoma and other neuro-ophthalmological confounders which can cause cupping, like optic neuritis, ischemic optic neuropathy, those cases, and retinal causes for pale disc, myopic fundus, and poor vision, which will prevent us from taking a good fields. If all patients were selected based upon inclusion and exclusion criteria, we took informed consent from all patients, and they all underwent thorough ophthalmological examination with the and we did slit lamp examination of the anterior segment with the help of 9DD, and classified this cup disc ratio normal up to 0.3, moderate 0.4 to 0.5, severe 0.6 to 0.8, and we differentiated with the help of disc cupping with pallor, without pallor, field defects, bitemporal, homonymous central defect, OCT RNFL with borderline thinning, global thinning, and imaging shows paracellular and cellular mass. This is the distribution of the total 85 cases. I will come to one by one. This 32 cases, this referred from Neurology Institute from our nearby center, and among this, all these 32 cases, they already imaged and found cellular or paracellular masses. They sent to us to roll out compressive optic neuropathy. The surprising thing is, among these 24 cases, field defect, OCT RNFL thinning cupping with present for the 24. But in the 8 cases, this is I want to highlight the non-field defect, no OCT RNFL changes, but only significant cupping. These cases are means already imaged with unfound out cellular or paracellular mass, but cupping only is the early feature. And the 12 cases which detected from our outpatients, 9 had field defect OCT RNFL changes along with the pallor, 3 had field defect only, no pallor on OCT changes, but 12 we imaged because we have either field defect or OCT changes. The 12 cases we imaged, we found cellular masses or paracellular. Surprisingly, these 5 cases, more than 3 centimeter in size, immediately they got date for the surgery, and 7 cases, very small lesion, less than 3, they got very late date for the surgery. And this is a distribution based upon percentage. You can see cellular masses are 62% from our study. Trauma cases comes at 12 cases. And the distribution, you can see the...
Relax. No issue. Take 5 minutes, deep breath, and then talk.
This is the distribution based upon the OCT RNFL changes. You can see OCT RNFL also showing temporal thinning more. This is means if it is the thinning is borderline or global, it is a temporal. And the disc cupping, you can see disc cupping with pallor when has the vision ranges from 6.6 to 6.6, that is poor vision. And field defect also, the patients with the cupping and field defects also has poor vision, and no pallor, no cupping, no field defects, 6.6 vision. So coming to the discussion part, we know the optic nerve cupping or enlargement of the cup disc ratio is widely recognized as feature of glaucoma, but non-glaucomatous cases like compressive optic neuropathy, ischemic optic neuropathy also can cause cupping. So what is the cause for this cupping? Prelaminar cupping is a shallow cupping which is more commonly associated with non-glaucoma, and the glaucomatous cupping usually laminar cupping which is deep. And so, non-glaucomatous cupping, usual dictum is pallor more than cupping, you have to evaluate. So, I am going to break that. The present study, disc cupping without pallor or OCT RNFL changes or field defects could also be early compressive optic neuropathy. So, early chiasmal compression due to cellular or paracellular mass and disc cupping without pallor or pallor less than cupping, what will happen? Such a patient comes to the OPD. There is every chance that general ophthalmologist may misdiagnose it as glaucomatous optic neuropathy or physiological cupping. My study is to prevent that. Though screening gives prevent vision loss by detecting early compressive optic neuropathy. Then what will happen if pallor is more than cupping? A late stage detection that will lead to subnormal vision recovery, post-op cumbersome surgery, resurgery due to residual lesion, subtotal decompression, recurrence, and craniotomy. You know the preferred route is endoscopic approach. We won't be able to approach that if the size of the lesion goes more. Yes, like that, the post-trauma cases, it also has every chance to misdiagnose as asymmetric glaucoma. So to differentiate that, visual field and OCT RNFL will help you to differentiate from glaucoma nasal. So these are the common few cases and these are the studies, but none of these similar studies show non-glaucomatous disc cupping without a pallor, also a feature of early compression. Conclusion: we are able to successfully introduce two non-glaucomatous confounders and as an early feature of compressive optic neuropathy. We hope other investigators are able to continue different aspects of the study, and this signifies the need of routine screening and follow-up with visual field OCT RNFL. This is one video of endoscopic resection. This is the less means a most accessible route and less morbidity. So if you are able to detect a case, you will be able to protect the patient, not only the vision, life as well. Friends, when Sanju Samson scores a century, we enjoy. Kerala gets century, gold medal in Santosh Trophy, we will also rejoice. One of our patient gets a reward, we will enjoy. So suppose we are able to protect vision as well as life, how marvelous it will be. Thank you, sir.
All these cupping, did you compare the disc size? So you have shown only the cupping, no? Whether you are comparing the larger disc or smaller disc, any comparison you are made?
Usually, no sir, actually I didn't. It's only cup disc ratio only taken.
So do you think that is also important?
Yes sir, definitely. And the cases we selected as physiological means cupping without pallor or field defect, that 31 cases we are keeping under follow-up. Is it a physiological cupping, or in due course of time will they develop a field defect? That we wanted to see.
So you didn't show any field effect, the bitemporal, no? You showed some cases at bitemporal hemianopia.
No sir.
No, I thought I saw bitemporal. One of the green slide background.
All this set.
Go there. No. Somewhere I saw bitemporal. No. Okay. So no bitemporal, huh?
No bitemporal field defects. It's already known that it's a compressive optic neuropathy. My highlight is without field defects and cupping.
I agree. But some you had bitemporal, isn't
yes,
it?
Sir. Yes,
You
sir.
had. So glaucomatous disc change can mimic a neuroophthalmic. That is understood. So you have any other study? Did you show any study where this kind of comparison that has been done?
Yes, sir.
You are not shown here. References still up. You didn't compare.
Okay.
No, okay. That is equally important, no?
Yes,
So how different it is from any other, or is the same in line with? So what you are trying to convey is it is better. You keep it in mind that it could be a cellular or paracellular, which is more life-threatening than vision-threatening.
Yes, sir.
Correct. Okay, ma. Thank you.
Thanks.
The next speaker is Dr. Anjali Prabhakar, and she'll be talking on clinical profile of childhood exotropia in a tertiary eye care center in Kerala.
Good afternoon, everyone. My paper is on clinical profile of childhood exotropia. Exotropia is the most common type of strabismus reported worldwide. It is defined as the outward deviation of either one or alternate eyes, which can be intermittent or constant. The clinical profile of exotropia as such has not been studied in North Kerala. So the aims and objectives was to identify different types of exotropia in children less than 16 years and the clinical presentation. The secondary objective is to identify the age of onset, age of presentation, birth history, and any ocular and systemic association, and to evaluate the motor and sensory status. The methods: it was a descriptive observational study conducted at Department of Pediatric Ophthalmology, Strabismus and Neuro-Ophthalmology, Contrast Eye Hospital for a period of 1 year from June 2023 to May 2024. Patients aged less than 16 years with a clinical diagnosis of exotropia, more than 10 prism diopters were included in the study. Exclusion criteria included patients with a history of strabismus surgery, patients with consecutive exotropia, and patients who were lost to follow-up. Coming to results, 200 consecutive patients with exotropia were analyzed, out of which 121 were females and 79 were males. Intermittent exotropia was the most common form of exotropia, comprising 67.5%. And notably, neurological association with exotropia was noted in 17.5% exotropia, followed by infantile exotropia, which was 10%, sensory exotropia was 2.5%, restrictive was 1.5%, and paralytic exotropia was 1%. Coming to age of onset and exotropia, the median age of onset was 25 months for intermittent exotropia. Median age of onset for exotropia with neurological association was 4 months of age. Coming to age of presentation, the median age of presentation for exotropia was 56 months. Coming to preterm birth, family history and exotropia, about 38% of exotropia with neurological association had history of preterm delivery. Coming to distribution of amblyopia, dissociated vertical deviation, nystagmus, inferior oblique and superior oblique overaction. About 13% of the children were amblyopic. DVD was there in 7%, 5% had nystagmus, 10% had inferior oblique overaction, and 1% had superior oblique overaction. Coming to amblyopia and exotropia, about 50% of the sensory exotropia had associated amblyopia. Coming to distribution of refractive errors, the most common refractive error we got was myopic astigmatism in 40%. There was no refractive error in 30%, and the least common was hypermetropia. Coming to distribution of patterns, in 70% there was no pattern strabismus, 25% had a V pattern, and 5% had an A pattern. Sensory evaluation was performed in 122 cooperative patients. The Words 4-dot test was done for distance as well as for near. Binocular single vision was present in 35% for distance and in 56% for near. Suppression was there in 50% for distance and in 30% for near. Diplopia was there in 15% for distance and in 14% for near. And stereopsis was absent in 22% of the population. Coming to discussion, the most common type of exotropia identified was intermittent exotropia, which was 67.5%, which was keeping up with the current literature values. Notably, 17.5% of the patients had exotropia associated with neurological conditions. So the reason for such a high prevalence of exotropia in CNS abnormalities could be due to the damage to the brain during the critical period of development, that is the initial 3 to 4 years of life. Our study also reported median age of presentation in 56 months. This delay in presentation may be due to the lack of awareness about the importance of early diagnosis and treatment, and it also may be due to some superstitions, and some people consider squinting as a good omen. Exotropia with neurological association had significantly more number of cases with preterm delivery, that is 38%, than other types of exotropia with a p-value of less than 0.05%. This significantly high number of preterm patients having neurodevelopmental disabilities is also described in a study by Jung et al. Myopic astigmatism was the most common refractive error recorded. So uncorrected myopic astigmatism and myopia are associated with defective accommodative convergence. This defective convergence can lead to exodeviations. Intermittent exotropia has significantly better fusion at distance and near compared to other types of exotropia with a p-value of less than 0.001%. This result is comparable to a study by Feridi et al. On childhood intermittent exotropia, which reportedly got fusion at distance in about 54% and at near in roughly 80% of cases. To conclude, intermittent exotropia was recorded as the most common form of exotropia. Exotropia associated with neurological cases were high in number, which had significant association with preterm delivery. Myopic astigmatism was the most common type of refractive error recorded, which emphasizes the importance of correction of refractive errors in management of exotropia. The findings further indicates the need for early screening and intervention, particularly in high-risk groups such as preterm infants and those with neurological conditions, to improve visual outcomes and reduce the burden of amblyopia. Limitations of the study: the accommodative and Virgin's facility has not been looked into in the study. These are my references. Thank you.
Why accommodated on this was not looked into? Because you'll it be part of your evaluation, isn't it?
Yes, but some children were not so very compliant, so we couldn't look into the
And what other reason could be for your high prevalence of neurological issue apart from the what you mentioned?
preterm delivery was there. Then low birth weight babies were also high, but we did not get a statistically significant value in low birth weight babies.
It could be, could there be a, if other centers do it, will they get the same sort of a value in their demography in their cohorts?
There was only one study which I got.
But that is
which
not from India, no?
No, not from India.
Okay, thank you.
Thank you.
So, no, did you classify, try to find out whether it was primary or kind of convergence insufficiency or divergence excess? Sometimes you get
Yes.
stimulated divergence
Yes.
also. You didn't take into that consideration?
No, that was not done in many patients. So only some children were compliant for all those things. So I got only a little
No, that is
cohort.
customary, no? For
Yes,
divergence,
yes.
for your exo deviation.
Yes.
That is how we do. And you said you ruled out consecutive also.
Yes,
That
yes.
is correct. So any refractive associations of this? Refractive status did you evaluate?
Refractive error was status was yes. We got myopic astigmatism as the most common refractive
What is the
error.
level of myopia?
Myopia, it was between moderate myopia, 2 to 4 diopters and all we got, sir.
Even hemetrope was there?
Hemetrope was
That
30%.
is what. So actually you need to customarily first classify them and find out what kind of exo.
Yes.
And then only you can associate with their other findings.
Okay.
Primary exo will not be associated, may not be associated.
Okay.
Thank you, ma'am.
Okay. Thank you, sir.
But all were intermittent, 50%. 57.